planned and then break for the case here. Our first speaker is Dr. Cameron Hari, who's going to talk to us about what are the indications, it says of, but I think I'm going to modify that to for placement and retrieval of IVC filters in 2015. Dr. Hari, thank you very much.
So thanks to the out-of-towners to coming to my hometown, Chicago. And we're going to kick off today by talking about probably one of the most avoided subjects in cardiovascular or vascular conference, which is what are the actual indications for these devices and what are we actually trying to achieve here. What am I just hitting the forward? Yeah. So before we start off with just a litany of tables, indications, contraindications, I just want to present a little clinical vignette that might summarize the entire session for the rest of the early afternoon. This is a case that I just had a couple of weeks ago, and I'd like to present it, and then maybe we'll touch on it a little bit later, get your thoughts about what I should do. I came across a 58-year-old woman who had no prior medical history. This was a couple of months ago, and she had a ventricular fibrillation primary cardiac arrest. It was not related to a PE, it was a cardiac event. She was resuscitated in the field after a traumatic CPR, pretty significant duration of chest compressions. Then she was hospitalized, stabilized, put on a respirator, ventilator, and she developed a hemothorax as a result of the traumatic chest compressions. Bilateral chest tubes were placed. She got multiple packed red blood cell transfusion because of the chest bleeding. And then subsequently, a couple days later, she developed a right iliofemoral DVT during that hospitalization. But because she had such significant bleeding in her chest and the chest tubes were still in, a vena cava filter was placed. Eventually, she recovered. She was started on anticoagulation, and she actually walked out of the hospital about 3 weeks after the day she was rolled into the hospital. So she came to me as an outpatient and referred for vena cava filter removal after she had been proven to be able to sustain therapeutic anticoagulation for a week or two after her discharge. So I said, okay, this is going to be an easy slam dunk. Let's come on into the hospital maybe next week, and let's take a picture and pull the thing out. But as you can see, it was only 40 days post vena cava filter implantation, and I hope you can see, I don't have a laser here, but I hope you can see projected up there that the vena cava filter is a little bit tilted, maybe 40 or 50 degrees, which is not uncommon, but one of the struts, one of the longitudinal struts might actually be outside of the long axis of the lumen of the vessel. It might still be embedded in the vena cava wall itself, but then you see one other strut, it's kind of sticking straight out in a perpendicular fashion and projected through the inferior vena cava. And of course, on an x-ray, you can't tell if it's perforated, any viscous, or just free floating in there, or what it is. So at this point, I stopped, and maybe we can think about what you all would do. Maybe we'll get to it a little bit later. So what would be your ideal vena cava filter? Would it prevent pulmonary embolism and reduce mortality? Well, I think that would be ideal. I don't know if we have that yet. Easily deployed via small puncture sites, we kind of have that. Deployed and retrieved from multiple different sites of access, we kind of maybe have that. Maintains caval patency, I'm not sure that we have that in the long run. Does not perforate the vena cava, maybe. Biocompatible and biodegradable, in the works. Not thrombogenic, maybe. MRI compatible, probably. Resistant to fracturing or migration, maybe. So in the ideal world, I think we have a maybe or a probably not for most of these. Well, so are we there yet? Are we getting there? Are we getting to an ideal vena cava filter? Well, it depends on where you're going, where we think we're going. Are we going in a direction where we want to continue to implant these devices, or are we going in a direction where we think there might be other modalities to prevent DVT in the long run and prevent venous thromboembolism? So there's a whole litany of approved vena cava filters. I'm not going to get into these right now, but you're probably familiar with the list. And the question is, are vena cava filters effective? And if we know whether or not they're effective, we can try to figure out what patient populations they're most effective in, and then we can decide what the indications would be. So the landmark and the most widely quoted study would be the PREPIC trial, and that's probably going to be presented a little bit more detail throughout the course of the session. But it was the largest randomized prospective trial, and really the final outcome was that at 12 days, or in the short term, there is a significant reduction in pulmonary embolism within the vena cava filter group as opposed to no vena cava filter, but did not translate into a mortality benefit. And when you project it out to a couple of years, more patients in the vena cava filter group developed symptomatic DVTs, although the mortality survival benefit was negligible or zero. So there may actually be an increased complication rate with the long-term presence of a vena cava filter. Multiple retrospective studies have shown conflicting results. Some report mortality benefits, some show no benefit, some show increase in all-cause mortality, and maybe even increase in DVTs with vena cava filters in place for a long duration of time. There have been no prospective studies comparing temporary and permanent vena cava filters in terms of their long-term outcomes, efficacy, and complications. And retrospective studies are showing similar rates of pulmonary embolism, DVT, and IVC thrombosis across the board. So then we get to what are the actual indications and what are our society guidelines telling us that we should do for prevention of mechanical prevention of venous thromboembolism. Well, there are some societies that we have that we're all familiar with. The Society of Interventional Radiology, and mostly in conjunction with the Society of Vascular Surgery, have their guidelines. The American College of Chest Physicians and the American Heart Association all have their guidelines. The guidelines are all based on, none of them are based on good level 1 evidence of prospective randomized studies. So we're left then with consensus from expert panels deciding what are or are not the best indications for inferior vena cava filter deployment. So the classic indications for which there's probably not much debate about are those patients who have venous thromboembolism events and they cannot take anticoagulation, either because they've proven to have a contraindication to it because of bleeding, or because they cannot take it for any other reasons. The extended indications are kind of that class 2A level of evidence or class 2A indication with still the maybe level 2 and 3 level of evidence, which is those patients that we think are probably high risk for developing recurrent venous thromboembolism, but we don't really know whether or not there's any proven benefit if they can take anticoagulation anyway. And then there's also the prophylactic indications, and I want to emphasize that there's currently no studies that have shown that prophylactic use of inferior vena cava filter has been shown to reduce the venous thromboembolism rate if a patient has not already had an event. So here we have a little table to describe the different society guidelines, and as you can see, there's a lot of variation across the board. So the absolute indications are somewhat consistent, and as I mentioned, acute venous thromboembolism patients who have a contraindication to anticoagulation because they cannot take it or because they have high bleeding risk, those patients should get inferior vena cava filters to prevent the pulmonary embolism and possible mortality rate in the short term. And then we get into the kind of intermediate or relative indications. And as you can see, the different societies across the board have differing indications for what they recommend. So I want to bring your attention down to the Society of Interventional Radiology in conjunction with the Society of Vascular Surgery recommendations, and those indications are probably the most broad, by broad consensus, and they include iliocaval DVTs, recurrent pulmonary embolism with a filter already in place, or prophylaxis for patients who are at very high risk for developing a DVT, particularly in the perioperative time frame, or severe trauma or burn patients, and also including those patients with neurologic injury, CNS injury. I think there's a talk later on this morning in the symposium discussing whether or not prophylaxis is indicated for patients who are not high risk for venous thromboembolism. Currently, there is no approved indication for prophylaxis in patients who don't have clinical VTE. This is just another summary of what we've just talked about in the tables, and I'll emphasize that the inferior vena cava filter benefit probably outweighs the risk in those high-risk populations that do not have an acute pulmonary embolism. Now let's talk a little bit about the complications. Why don't we just put these vena cava filters in and just leave them in forever? Why should we be taking them out? Well, insertion-related complications are not nil, even though we all think that we have a 0% complication rate from just the acute procedure itself because it's a simple, quote-unquote, slam-dunk procedure. Complication rates from the actual procedure itself have had a wide published range, and those include puncture site-related hematomas, misplacement of the device, migration or failed deployment of the device, and vena cava perforation at the time of deployment. Access site DVT probably occurs more commonly in the femoral system, but those can occur also. Filters can migrate or embolize over the intermediate and long term. Stent struts can fracture and penetrate the vena cava. Whether or not they perforate the viscus is a separate issue. Inferior vena cava filter thrombosis probably occurs more over the long term, but it can occur in the short term as well, especially in those patients who have established iliofemoral DVTs. And lower limb edema and post-thrombotic syndromes can also occur in patients, including recurrent pulmonary embolism. They don't completely across the board prevent pulmonary embolism themselves, which is the primary reason we're deploying them. So why retrieve? Well, as with everything in medicine and everything here in this conference, you have to weigh the good with the bad. The benefit we put them in for is to try to prevent recurrent venous thromboembolism and pulmonary embolism and hopefully mortality. But the bad side is that there's complications associated with it. So why should we retrieve? Well, it's becoming more and more obvious that complications can be avoided if we remove these filters promptly. The data does suggest that as filters are retained, the more long-term complications may occur. We can probably remove most vena cava filters safely in the short time frame, but as months and years go by, that success rate comes down and the complication rate goes up. So the question now becomes, is there a sweet spot for retrieving these filters in terms of timing? Does 1 week matter or does 1 year make a difference? Well, there's been one major large retrospective database review to examine this question, and it was a review of 188 studies, original publications for the past decade, and the conclusion after statistical analysis was that for patients with retrievable inferior vena cava filters in whom the transient risk for pulmonary embolism has passed, quantitative decision analysis suggests that the benefit to risk profile begins to favor filter removal if you can get that filter out within the first 2 months, 29 to 54 days after implantation. So I would advocate that filter removal promptly after a patient has established that they can tolerate anticoagulation or has left that high-risk window for venous thromboembolism with or without anticoagulation is preferred. In conclusion, the only indications for inferior vena cava filters that are widely accepted are in those patients with acute venous thromboembolism with absolute contraindications to anticoagulation or in patients who have failed anticoagulation with recurrent embolization despite the anticoagulation. There may be a role for inferior vena cava filter deployment in patients who are at high risk but don't meet criteria number 1, and prompt filter retrieval as quickly as you can when you weigh the pros and the risk to benefit ratio for every particular patient is crucial, as complications may accrue soon after implantation. And I want to just quickly go back to give some thought about my case. There was a lady who was on anticoagulation for only 2 months after a venous thromboembolism, and now she has a vena cava filter that with one strut that seems to be perforating out perpendicularly. I'd like to know what the panel and what the audience thinks I should do. Thank you very much. I have 30 seconds for an answer,
Yeah,
or else I'm on
well,
my own, guys.
One-word answer, blurt it out. What do you want to do? Take it out. I'd vote to take it out.
So what I decided to do is that this woman, she hasn't completed she was on 6 weeks of anticoagulation, so I wanted her to complete a 3-month course of anticoagulation before feeling that I could safely pull the filter out. So I'm going to keep her on it for another 3 weeks, discontinue her Coumadin, and then take the filter out. I may or may not get a CT scan to make sure we're not perforating some viscus before I take the thing out, maybe the day before or the morning of the procedure. Well, so that's what I want to know. I should still take it out? I probably will, yeah. Thank you.
Well, I got a question for you. So you said you're going to discontinue Coumadin and then take the filter out?
Yes.
That's interesting. In our institution, we have discordant views on that. Half the people will say the patient needs to remain anticoagulated when they take it out, ostensibly leading to venous trauma, et cetera. And the other half will say they have to be off anticoagulants. And I don't know what the right answer is. I'm just curious.
This particular patient, my thought process in this particular patient, I'm considering this to be an induced venous thromboembolism without long-term risk of VTE. So I just wanted to complete a short-term course of anticoagulation anyway. And then I'm going to keep her off it completely.
Right, but would you pull that filter out while she's still anticoagulated versus stopping anticoagulation?
Yeah, so as I mentioned, I think in this case I would discontinue it. But that's interesting.
A question for you. How much DVT does she have left?
The DVT has resolved on ultrasound.
Thank you very much. All I know is if you think, every time I think this is a controversial view, how many filters to put in and when to put them in, I think of the country of Norway, which is a very sophisticated medical environment. And last year they put in 6, maybe 7 filters in the entire country. At Mayo, we put in easily 6 or 7 a week. So somebody's off on the balance there. Our next speaker is Dr. Nilesh Goswami, and he's going to talk about, is there a benefit to the prophylactic use of IVC filters? As if this isn't controversial enough already. Have at it.
Well, I'll try not to sound like a broken record, and said that to my children once recently, and they asked me what that meant. Which didn't make me feel good to start with. So let's get started with this. And essentially what we're talking about when we're putting in IVC filters is pulmonary embolus. That's the one thing we're trying to prevent, in particular, obviously fatal pulmonary emboli. And as you see on this slide here in the upper left-hand corner, since the adoption of multi-detector CT back in 1998, we have seen a steady rise in the diagnosis of pulmonary embolus. And along with this, obviously the main therapy being anticoagulation, we've also seen a rise in anticoagulant complications, particularly bleeding. And it's mainly in this case, in these particular situations, where an IVC filter plays some role. Clearly, the use of these filters, as Dr. Rook has just pointed out, in the United States has been very prevalent and increasing, particularly with the adoption of retrievable filters. The fact that they can be removed later when no longer needed is a very attractive option, and they're typically placed for contraindications to anticoagulation or prophylaxis with regards to various high-risk surgeries. Although we put in a lot of filters, the data regarding the efficacy of these filters is still somewhat poor and lacking, and you can see here just a small minority of trials are prospective, with the vast majority being retrospective or case reviews. And in fact, there are no real randomized studies that compare an IVC filter to anticoagulation treatment itself, and similarly, there's been no trial that's compared the efficacy of these various different types of filter designs. One of the trials that's already been mentioned in the previous talk is a randomized trial. It's a PREPIC study, and this randomized 400 patients with proximal DVT to either filter or no filter, in addition to anticoagulation. And they followed these patients long-term for up to 8 years, and what they found is that there was a benefit to receiving an IVC filter, in that you did have a lower rate of pulmonary emboli compared to those patients that did not receive a filter. This, however, came at a cost, with increased DVT rates seen in the filter group compared to the non-filter group. When they looked at overall mortality over this time period, there was no significant difference in this small randomized study. Nonetheless, even though in DVT there may not be a mortality benefit to IVC filters, it does appear that there may be one, particularly with unstable or massive pulmonary emboli. So on the left there, you see in the last 2 graphs that patients that presented with unstable pulmonary emboli had a benefit in terms of mortality when they did receive an IVC filter. In a study published a year later, on the right, you see that with vena cava filtration, there was a mortality benefit as well. Once again, these are a population of unstable patients with pulmonary emboli, and it didn't matter whether they were treated with anticoagulation, embolectomy, or thrombolytic therapy. There did appear to be a benefit to receiving a vena cava filter with regards to mortality. This data was also further supported in a registry that was reported in JACA last year. If you look at PE-related deaths, those in the filter arm had a statistically lower PE-related death rate compared to those receiving no filter. And once again, pretty consistent in the data here is the fact that this benefit did come at a cost of recurrent VTE being higher in the filter group as well. There is some population-based data as well. This is a fairly large study looking at 3,632 patients that were treated with a filter, and compared those to 64,000 patients that were treated in the control group. And in the conclusions, you'll see there in the first sentence that there was not a significant reduction in the one-year incidence of rehospitalization for PE in this group. But once again, what they did find was that the patients that did receive a filter had a higher rate of subsequent DVT and hospitalization in that regard. As was pointed out in the previous study, there is some confliction in terms of the data with regards to mortality in IVC patient populations. And here's a study totally contradicting the one I showed you previously, in that it shows an increased mortality in patients that received an IVC filter, although this was a much more stable population than those with hemodynamically unstable PE. Although they may be beneficial clinically, we cannot forget that these filters do carry complications, and this was summarized in the previous talk as well, hence the broken record. But nonetheless, I will just touch on and show you examples briefly of some of these, including migration, IVC thrombosis, perforation, and recurrent pulmonary emboli. And here's a case of a filter that's completely migrated into the lung and being snared out by Dr. Williams in Michigan. This is a filter here with pieces missing from it. Some of the support arms are missing, and when we looked up into the chest, there was some in the lung, one in the heart, and some in the other lung as well. Here's an IVC perforation from filter placement with resulting in a lot of gut edema around the intestine. And in fact, one of the barbs goes very close to the aorta as well. And this was subsequently surgically removed and fragmented into pieces. And there's the IVC after it was surgically repaired. The IVC can completely thrombose. This is obviously a condition that carries a significant acute morbidity associated with it. And these patients are fairly miserable, and this is a difficult problem to deal with. So I just want to share with you now a case that I was asked to participate in several weeks ago at our institution, of a 33-year-old woman who presented with a 4-day history of bilateral leg swelling, with the left being somewhat worse than the right. She had a history of a uterine fibroid, but no prior history of clotting or thrombophilia, and she didn't have any other risk factors. She had a lower extremity venous duplex that showed partial occlusion of the left common femoral vein, and a lot of rouleau formation in the veins in that leg, and they were difficult to compress, most likely because of the increased pressure that this large uterine fibroid was placing on her IVC and proximal iliac veins. Here's her CAT scan. This is actually the suprarenal IVC at the level of the liver. And one of the issues in dealing with this case was that the diameter of the IVC there was almost 35 millimeters. And then in subsequent cuts here, maybe, you'll see that the large uterine fibroid in the center of the screen there, completely compressing the IVC itself. And then this is a little lower in the pelvis with really complete obliteration of the venous drainage to her legs. And so this was an issue. She had a large fibroid compressing her IVC. She had acute DVT in the iliacs that were actually a bilateral, confirmed on a venogram. A hysterectomy was planned, and I was asked to put in an IVC filter. You know, the question is where do you put it and how do you put it in? Because the infrarenal IVC is completely occluded, as I'll show you, and the IVC above the suprarenal IVC is very large, and so the filter has a high risk of embolization. And so, you know, what's going to happen in the end, ultimately, when you take the fibroid off and do a hysterectomy, is all this clot in her pelvis going to go immediately to her lung? And so, what do we do? You know, or do we just gamble with the situation and go for it, or try to think of something unique that we can address this with? And this is the route we chose to go down in terms of using this angel catheter. This is not FDA approved in the United States, and we obtained some emergent use permission from the FDA and from the company to use this device. But essentially what it is a triple lumen catheter that has a retrievable filter on the end of it. I was fortunate enough to train with Luis Angel and gave him a call, and he helped us walk us through this. And so I just wanted to show you some of this case here. This is the pre-procedure venogram here. The common iliac's basically clotted both sides. The IVC is just completely obliterated with no inline flow coming out of either leg, really. Can you guys advance to the next slide? There you go. And this is a venogram of the IVC that shows essentially that there's no inline flow until you get above the liver. And then once you get above the liver, the IVC looks very large with no residual clot there. This is the Angel catheter being deployed. It's fairly hard to see because of its thin struts, but essentially you unsheath it like you would any other filter. The advantage is that it stays connected to that central line, and thus, even though it only expands to 30 millimeters, it's tethered and comes out through the groin, through the femoral vein in the groin. And then you can inject through the distal port here, and that's just showing it just at the level of the liver. We scheduled her for her hysterectomy in the cath lab, just in case we needed to use perfusion, whether it be a thromboembolectomy or for an angiovac, if we got massive embolization into the filter itself. So that was a little bit amusing to most people. Here's the uterine fibroid as it's being removed. This was a small 100-pound gal, and this thing really resulted in her clinically looking pregnant. I mean, it was fairly large. And lo and behold, after the IVC was decompressed, inline flow was restored from at least the right side. The left side looked to be chronically occluded. We actually couldn't pass a catheter up there too easily. And she likely has some component of May Thurner with this. And so with there being no residual clot in the IVC itself, we recaptured the device and then removed it, pulled it down to an infrarenal position in the IVC, let her heal up from her surgery for 2 or 3 days, started her on anticoagulation, and then subsequently pulled the filter out. She did great with that. So what about IVC filters in this particular situation where you're potentially going to do an intervention for DVT, and there's always some concern about large volume clot going to the lung in that regard, and this has actually been published by one of our panelists here, randomizing patients in this situation to either IVC filter or no IVC filter. And what you'll see there in the first sentence of the results is that PE developed in 1 of the 14 patients in the filter group and 8 of 22 patients in the control group. And so the conclusions here were that IVC filter implantation during intervention does seem to reduce the risk of iatrogenic pulmonary embolus. So in conclusion, PE is obviously a significant health issue that carries with it significant mortality. IVC filter data, as I stated, is limited. The filters do appear to reduce the rate of pulmonary emboli and may reduce mortality, although this data is conflicting. This comes at a cost with increased VTE rates in patients that received IVC filters, and we can't forget that these devices as well carry complications along with them. These new IVC filter designs, however, may mitigate some of these complications that are seen with the currently available filters, and I can't stress enough that prophylactic anticoagulation is the most recommended measure in these patients for prophylaxis. Thanks.
Thank you very much, Tom.
Okay, well, I was going to say, our next thing is a pre-recorded case, and I think that Patty's going to handle that for us, so.
This one, yes, I am. Oh, well, we're lucky we have a good library of these cases, and we're going to show a relatively short interventional case. I believe it is a May Thurner case again, but every single case is slightly different in terms of the judgment and the images. So this is a case from Arizona Heart Hospital that I did about 2 years ago. So we have it here to show you today. I think there's some audio, I'm not sure. Thanks. It's great to be with you today. We're going to show you a case of a May-Thurner iliac compression, which is actually clinically somewhat subtle in certain ways. And what we've done is we've investigated this patient with diagnostic venography and with IVUS, and it somewhat shows how the venogram isn't too impressive, but the IVUS is. So what we'd like to do is introduce this patient. She's a 64-year-old woman who came to me for some additional sclerotherapy, but when she said that her sclero had turned into a medial malleal ulcer before, I thought there's got to be something else going on in this left leg. And her history shows that she had a DVT 30 years ago following a hysterectomy. And then probably about 1 year ago, she had an episode of cellulitis and went undiagnosed with some tibial DVT. So her prodrome is also that she has a heavy left leg, she fatigues, it gets tight, and it's larger by 3 centimeters in the thigh and 1 centimeter in the calf and ankle. So all that being put together sounds like a story for a May-Thurner compression that's never been diagnosed, and been giving this lady venous hypertension for years with a couple of episodes of DVT. So we brought her in here today for an evaluation, and we'd like to show you the first venogram. The first venogram shows that the femoral vein looks good, but on intravascular, on the ultrasound itself, there was some non-phasic flow in the external iliac. So that suggests there's a proximal obstruction. And on the digital subtraction of the iliac, you can see that it looks darn good. There is an area that's somewhat low density near the common iliac, but the telltale sign is that there is stasis of contrast in the external iliac area, and a little bit of a filling defect, which we can see then again on IVUS. So now we're doing the IVUS, and you can see it gets very narrow in the common iliac. So it's about 2.5 millimeter minimum diameter, but it measures about 14 to 15 on the longitudinal axis. So this is a good patient that has a definite compression greater than 50%. And of course she's supine now, so when she's upright, it could be even more of a compression and evidence for May-Thurner. She doesn't have very many collaterals, but we could force the collaterals if we did with a Valsalva, but she's comfortably asleep thanks to Kevin Olina. So what we've done now is we've put a Amplatz wire up, and we've measured with both a balloon, a 16-bore balloon, as well as our IVUS. And we've been able to determine that this is a good stent size, a 1690, which will extend far enough down into the external iliac. So we're positioned now with a road map, and I put the IVUS probe up into the cava to where we want to advance the stent. And we're about ready here now to deploy the stent, and then we'll look again with IVUS. So we have it all ready to deploy. Are we live, Casey? Now I would like you to go off road map at this point. Okay, now watch this. We have some needles in place as well. This is a 16 stent, so as it opens, we'll see it flare. And we want it just up into the cave a little bit, not too far. I'll pull it back down where we're just by the bifurcation. And we'll extend it down into the external iliac. And I'll hopefully have good apposition with all the walls. And so now it's deployed. Good, and now we can do a follow-up venogram. And if you give me full strength contrast, I'll inject here. Good. I'll inject through the sheath, and we'll watch it come up through there. And this time we shouldn't have any evidence of stasis. Okay, live. Here it goes, come to counter. Flow is going quickly through as it comes through, and it clears. So that looks like a good result. We'll go back with IVUS and then be able to show you those images when we complete them. And the position is good because it's right at the bifurcation, not too high, but obviously we've accomplished the common iliac area nicely. You can see the flow coming in from the right side where it washes out. So this is a good position for the stent. Let's go up with the 16 balloon. We'll dilate our stent just to make sure it's completely opened against the wall. Can you give me an empty syringe, please? You need those balloon wings really far down so you go up into a stent with it open. It's nice to use a new balloon when you're dilating a stent. Okay, get the air out. Okay, there you go. Hold on. Okay. We'll go live, please. I'm going to go right to that common iliac lesion. Carefully into that area where it's tightest, right there. Okay, go ahead and inflate the balloon, please. It'll foreshorten slightly when we do this, but we have margin for that. Go up to 4. Good, okay. Okay, now come down slightly. Just go ahead and deflate. We always want to extend that wall stent up just a little bit beyond where you want it to position, so when you dilate and it foreshortens slightly, you have that margin. Then we'll come down here and go up one more time. See how I'm staying above the wall stent because chance of harming the balloon. That just a little bit. Okay, that's enough. Come down. All right, and then we'll go back with IVUS. Okay, we'll take that out. Take this off. Makes it easier. Okay, balloon is going to come out, and we'll do an exchange for our IVUS. So in this patient's case, her symptoms are really related to a proximal obstruction, plus the accruance of some DVT that is residual in the tibial vein, so that affects her calf muscle pump. So we'll see how much relief she gets from opening up the proximal narrowing and high pressure. She does not have any reflux in her saphenous vein. She does, however, have reflux in her distal femoral and at the popliteal. And interestingly enough, she does not have deep reflux on the right side. So that's another clue that she had a left proximal obstruction. And I think clinically we're missing a lot of these because we don't connect the dots with the signs and symptoms. She's a mixed bag because she does have some reflux from long-standing venous hypertension proximally. But when we relieve this obstruction, she'll get a lot of relief, and then we can reevaluate her valves with a standing position. At least it might mitigate against further damage to the valves. Now, she's a good example of a patient in whom saphenous ablation, or in her case, foam injection of some varicosities, wasn't a good idea because she had a significant amount of venous hypertension coming from a proximal stenosis. And those are the kind of people that actually get worse if you do the superficial system without correcting the underlying lesion. Okay, this will be the IVUS. We use the 6 French eagle eye for these veins, even though the veins are somewhat larger than coronaries, obviously, but we prefer the imaging that I get here with this. And this is an 014 system. There is an 018 system available. We'll go up here with this monorail, 6 French. Now, left over from her episode 30 years ago are some synechii in the external iliac vein segment. Do you want to ring down, please? There you go. So we see those. This is the normal femoral vein in her thigh coming up. And once we get to the common femoral external iliac, you see some webbing, which is actually residual unresolved old thrombus right there. You see that? There's like a web effect in the vein from an old unresolved or completely resolved thrombus. And this is external iliac there. See another area where there's a little bit of webbing or synechii, but not obstructing flow, to my estimation. And then we see the stent in place, which is well opposed to the vein. The vein is actually just slightly larger there in one diameter. And here we are coming up live into the common iliac segment. You can see the stent is well opened, and there's the IVC. Now, if you would put on the chrome, please. Chrome foam. And we'll show you with the color flow. Record. Okay. And we'll pull back from the IVC, and you will see that the stent is not too far in the IVC. There's good flow from the right side. And there's the thickening, the high density echogenic material from the old May-Thurner compression. And the stent is open with good flow through that. There's a bit of an area where the vessel is actually wider in one dimension than it is the stent, but the flow will go through there. There won't be any problem with any thrombosis or anything, and the hypogastric will empty nicely into there. And there we're back into the normal vein. And those little web effects down there distally. Okay, thank you. Well, I think that's a good result. It'll really help her clinically, but of course we won't know until we take the sheath out and she's able to walk and tell us for certain. But I'm pretty sure this will help her a lot. Thank you very much. I want to mention that, let's see, we did her several years ago. She is doing very well. It did resolve her problems in her left leg. But she remains on Coumadin because I think she turned out to have a genetic factor 5. She lives in Yuma. It's real hot and dry too. So I wanted to mention one of the biggest problems that people get into when they first start doing these cases. This was a popliteal approach. Sometimes people prefer a femoral approach because the patient's supine and you're just stenting an iliac vein. But be careful when you're first starting, you're using these large balloons, particularly the Boston Scientific large balloon, which is a good balloon, but the wings don't come down very well after you deflate it. And I've seen several cases, in fact, it's happened to me, but other people send me pictures of those stents can move if you don't really deflate the balloon. So take the time to watch the balloon completely deflate. Get rid of all the contrast before you move the balloon after you're super dilating these stents afterward. Because you can actually tear the balloon on the stent. The balloon can turn into like an upside down umbrella, and you can end up with the part of the shaft coming through your sheath and the rest of it stuck on the other side of the sheath. So what happens what do you do when that happens? Keep your wire there, get a bigger sheath, and you have to pull the whole thing out as much as you can, cut your balloon shaft, get it all off the wire, and then reinsert a larger sheath to get it out. So these are the kind of things that you have to know how to do, because something can go wrong when you do these balloons. The balloons can pop on the bottom of the stents, and they can tear, and part of it can stay hooked to the stent. Worst possible thing, though, is that they can pull the stent out of place. And then you've got the stent way down below your lesion, and it's sitting right there where your sheath is. Now what? The last case I heard about this happening was they tried and tried and tried. They were screwing up the sheath site, and they couldn't get it out, and they just decided to stop and take her to the OR, did an incision, removed everything. She rethrombosed her whole leg. Of course, then they couldn't use lytic therapy because she just had this surgery. So this poor lady went home without a stent, with a whole new clot, and didn't do too well. So, I mean, that's a very bad scenario. But when you're doing anything, as I always taught the residents, think about the worst possible thing that can go wrong, and then hopefully it won't, because you'll prevent that with, good judgment. So that's about all the time we had for that case. And thank you very much.
All right, folks, from here it gets tricky. Our next speaker is going to be Dr. Razavi. He's actually scheduled for 4 o'clock. Dr. Dean is going to swap that slot with him because we've got to get Dr. Razavi on a plane here and get him out. So he's going to come in and talk to us right now about treating chronic venous obstruction below the knee. Oh, nope, I'm sorry. He's going to talk to us about what do we do when a wire won't cross a chronic venous ilio femoral occlusion, or what to do when routine recanalization fails, I guess.
Thank you. I did plan my departure fine, except those of you who are aware, United is down for the entire, looks like, country. And so if you're on a United flight and you're going out, you come to airport with me, because there's going to be trouble. All right, so what do we do when routine recanalization fails? When the catheters and wires don't work. And this happens not infrequently on the venous side. Here are my disclosures. Now, who's at the higher risk? Can we tell that ahead of time? It's really difficult to determine who's going to fail your catheterization or your recanalization ahead of time. But there's some clues. One of them is that duration of occlusion. The longer the patient has had occlusion of the vein, the higher likelihood that simple catheter wire may not work. Length of the occlusion, if entire IVC is occluded and it's been occluded for a couple of years or 10 years, then you're a higher chance that you may need something more than that. Caliber of the occluded veins, the smaller, the more shrunken the veins are, the more difficult they are. A concave appearance of the cap. If you're hitting a concave appearance, just forget the wires and the wire. You need sharp recanalization. You need something else. And scarred down veins, as we talked about. And here's a case, for example. Look at that. This cable is almost non-existent. This cable has been occluded for years and years and years. And this patient, obviously, when they come, we know that the chances of just a simple hydrophilic wire catheter is going to be on the low side. We have to revert to other options. Here's another patient, a different patient, iliocaval segment. Right there, as you can see, the iliac vein is again, non-existent. Looks like just a vestigial little tissue right behind the artery there. But this has been occluded for a long time. So this is a slightly higher likelihood. When you see something like this, now this happens to be in the upper extremity, you see that concavity of the SVC right there? No wire is going to get through this. As soon as you see this, you're going to have to revert to other means. Now in this case, we did sharp recanalization. For sharp recanalization in this location specifically, I'd like to know what my target is, and you go from above and below, and you get through your angioplasty, you stent it, and it looks good. Now, what options do we have when this sort of situation happens? One is that if you're antegrade or you're retrograde and that's not working, well, go the other way. Thankfully, in the veins, dual access or even triple access is not that difficult. If you're an iliac vein and you're coming through the popliteal or common femoral, it's not working, go through the jugular. And you can be able to frequently get through one way or the other. You can use coaxial or triaxial systems. That gives some stiffness to your system, and you can pushability and transferring forces from your hand to the tip of your catheter a lot easier when you have triaxial or coaxial systems. Then you get into the sharp recanalization. And back end of a hydrophilic wire, or what I do nowadays, actually I use the back end of an 014 wire. It is very easy. It's like a needle. It goes anywhere. You just have to make sure you direct it in the correct place. Transeptal needle is another common one that we use, but mostly for areas where there are tortuosities involved or curvatures, because you can adjust the curvature of that needle and go in the direction where you think you need to go. People in the past have used tip sets. I think it's an overkill. You don't need a tip set for these things. We now have enough good low-profile systems to get to do sharp recanalization. Thermal recanalization has been done using the RF wire, and there are 2 reports in the literature on this. The shock wave recanalization, I've done only one case with this, really, again, overkill. You don't need it. Most of the time, you can do sharp recanalization back end of the wire, transeptal needle. You don't need those. Let's go over some examples, and the best is to show you some cases to get a good feel for this. This is a poor 18-year-old who had DVT, was not treated properly, and then a year later, now we have chronic occlusion of the iliac vein. And this is what it looks like. So we approach this thing from below first, as you can see. It's coming through the popliteal. And at this point, we tried multiple projections and different methods to get up. It just could not. Everywhere we went to, it was just a hard, fibrotic tissue, could not recanalize. So we went the other way. We went from the jugular, turned the patient around. As you can see, now there's a sheath and a guide catheter from the jugular, and then a coaxial system, and then down at the common femoral, where the vein is somewhat straight, we use the sharp recanalization back end of the wire, got across, and you can see I have targets from above and below, and got through. Frequently in these patients, if you get 035 systems, balloons and things, because they're higher profile, they don't follow well. And so we use 014 when that happens, and then you start with small coronary type or small low-profile balloons, and then work your way up to 035, which was done here, and then you stent the whole thing and you get good flow. Now let's look at sharp recanalization. Knowledge of the course and relations of the vein are very important to prevent bleeding and complications, particularly if you're in the subclavian brachycephalic veins. Lower extremities are a little bit safer. Up here, you got a lot of critical structures around the brachycephalics. The aortic arch sits there, the subclavian artery sits there, so be careful. You need to understand that area very well. On the table, Dynos CT imaging can be very helpful in those situations. Most modern equipment, angiographic equipment, have this feature, and you can actually use it. If you're not into liver work and that sort of stuff, you may not be familiar with this. It's easy to do, and it's very helpful. But overall, it's a safe approach. Sharp recanalization is a safe approach. And let me show you an example of that Dynos CT. Here's a lady who has aortoiliac occlusion. She's 42 years old, and she has had a catheterization of her umbilical vein as a child. So the chances are that, and she's always had lower limb swelling, and now we have the legs look pretty purplish. Very, very possible that this patient has had occlusion of that cava and the iliac veins for 42 years. So here it is, as you can see from the right side, looks like the wire is going along the course of the cava. And it just something didn't feel right. And I checked it out on a Dynos CT, and here's a Dynos CT. Look at that wire. The wire. Let me see if I can find the laser on this thing. Where's the laser? Over there. Here we go.
I think I moved your slide.
That's all right. Okay, here's the wire right there, okay? The course of the cava is down here. As you can see, it's a sort of non-existing tissue, but we're up there. Clearly, we went through some collateral. So if I had put a balloon up there, that would have caused bleeding, okay? That would have been in the middle of nowhere. We probably would not have been able to connect that into the cava up at the suprarenal cava. So this is where the Dynos CT on the table helps a lot. So we came back and recanalized and went in the correct direction and stented. Here's a patient with an upper extremity, and the reason I show this is because this is the area that is particularly problematic if you're outside the veins, because there are a lot of critical structures sitting there. So this is chronic occlusion, probably 2-3 years since the pacer wires were placed. But the good thing here is that you got some pacer wire in there. Can you advance those the videos for me? And so you can hug those pacer wires and use there it goes. Use the back end of the wire and just come on up. Yeah, do the right hand side. And you can see we're hugging those wires and coming right up on top of them. Now, if you go the other way, you can use transeptal needle. And this was, we got across, and you can see the wire is across from the bottom. This was ballooned and stented, and flow got back. So now, literature is mostly case reports on this. Early series was by 1999 by Farrell and Elvira Rang, and they only had 6 patients. But the largest series in the literature is 44 patients, and that's on all in dialysis patients. It's all in the arm, which is actually more common to be very fibrotic and very problematic in these situations. But they were very successful, 91% success rate in recanalizing these things. Here's an example, 74-year-old worsening bilateral edema, times 8 months, history of filter placement. Can you run those videos for me? And this is access from the right and the left. So we got upper femoral access on both sides, and here's this, you can see occlusions. And the reason I went through the femoral rather than the popliteal, because the whole cable was occluded also. I needed more torqueability and pushability once we got there. Usually I do these through the popliteal. Next, and now here it is, wire on that right side has partially up, but we're stuck. We can't advance our catheter behind it. Can you run that for me, please? Here it is, it's stuck, and you can see it's pushing my sheath back. So what we do in these cases actually use a system that has been available for about a year from Cook called the Triforce catheter. Now look at that. This is real time. See how easily it went up. This is a triaxial system, and it's engineered for these type of things. It actually has made our life a lot easier since we've started using this system. Frequently, I don't need to do sharp recanalization. In the same patient, I'll show you, here's when we are recanalizing the other side. So we've recanalized the right and cava through the filter, as you can see. Now I'm recanalizing the other side, and I'm using the balloon as a target for sharp recanalization. Couldn't do it. So what we did is this. Run the video, please. Look what happens to the wire. That's a hydrophilic wire, okay? Stiff, straight glide wire. And it's going down in that direction, probably creating another iliac, common iliac on the other side. So we switched our system, and that's a Triforce right behind it. As you can see, I advanced the inner cannula of the Triforce, and boom, popped right through. Okay, so this actually system has helped us quite a bit in trying to treating these patients. And then we took the filter, dragged it out of there. Didn't want to come, but we took it out. Can you run those 2 videos? And this is post-stenting, angioplasty stenting on also, so everything is open. Okay, so very good flow. So in conclusion, alternative recanalization tools, particularly sharp recanalization, is very important, and it increases the likelihood of success, and they are safe to deploy and employ. Be careful around the brachiocephalic veins. Detailed knowledge of venous relationships, however, are very important. Thank you very much.
I hope you get your flight. I hope you get your flight.
Oh, thank you.
Thank you, Mahmoud. Appreciate your willingness to be flexible here. We've already heard a lot this afternoon about putting hardware in, stents and filters and things. Every once in a while, they have to come back out, and sometimes it's not the easy way. Our next speaker is Dr. Al-Masri, and he's going to tell us about complex IVC filter retrieval.
Thank you. My name is Fakir Al-Masri from Lakeland, Florida. I would like to thank the organizers of the meeting and Dr. Golzar for inviting me to this meeting. These are my partners. So basically, we practice in Central Florida. We have 5 hospitals. We place about 500 filters and remove about 200. We became Center of Excellence for removal of these filters over the years. We all remember when the FDA came with the recommendation in August of 2010 that the implanting physician, which is you, is responsible for the ongoing care of the IVC filter and remove them as long as the IVC filter is no longer needed. FDA came again with a similar recommendation in 2014. And of course, our friends, the lawyers, capitalize on that, and they have all these ads all over. The Super Bowl at 2012, there was an ad at the Super Bowl, which is the most expensive time, about an IVC filter removal. So, basically, current practice, we always schedule these cases for an hour block. Most of the filters come out quickly within 10 minutes. Some of them need additional techniques, which I will share with you today. Depending on the filter and the hook, we have high success of removing these filters. This is a case where in the AP view, the filter looks straight, but if I could convince you and you look at the cablegram, you see a filling defect in the, around the hook. And as we were taught in residency, one view is no view, so you oblique the tube and you see the hook is actually embedded. So we try with the alligator forceps, and the filter actually flips upside down, and we're able to retrieve the filter from a femoral approach. This second filter, which was already attempted by somebody else, where when you look here, you find the hooks or the legs are everywhere. And we developed this technique where we place a 16 French sheath, 45 cm, and then through which we place a 9 French, 55 cm. And we try to gain access into that area between the hook and the neck. And by placing that, we were able to snare the filter back and fold the filter in half. And this works with this filter and the second generation, which are the Recovery, the Meridian, and the G2s. By having this technique, you're able to, once you put a SAS catheter, the combination of the SAS catheter with the 9 French sheath, you could actually create an innumerable number of angles where you could actually guide your catheter into the area of the neck and fold the filter in half and remove it. This is another case which in one of the smaller hospitals we have, where I got a call that the filter went through the cava, and they're taking the patient to the operating room to remove it. The patient is a 90-year-old ICU patient, and I just knew that this patient was going to survive. So we convinced them not to operate and to bring the patient back, and since it's a long drive, so I asked them to do a CAT scan, and here you see the filter actually going through the cava. So the technique we use is basically go with the SAS, go above and over, because you can't get around the legs. The legs here are close to the cable wall. And if you see there's a little bit of extravasation out of the area of the legs, and if this would open, then the patient would actually bleed. Taking the SAS above and over, snaring it back, you were able to constrict all the legs. And by doing that, you could take the filter out. And that was removed with a cone. That was old generation Recovery. This is a filter which was placed, if you could run this video, please. And sometimes the legs of the filter does not release from the cup. And this particular physician actually pushed the filter up, which is something you should never do. So we were told that the filter actually did not open. And actually, the filter is not even in the cava. And if you could play this video. So if you, next slide, please. So we use the same technique as the previous case, where we go with a SAS catheter above and over and snare it back. If you could run the video to the end, please. And you snare it back, and basically we're able to get the legs and pull it out, also folding the legs into the 16 French sheath. So this is a technique in slow motion. If you could just run the, yeah. Okay, well, that's a SAS, and you take the SAS around it and snare the wire out, and basically and basically get all the legs. Use your 9 French sheath as your snare, and by pulling it into the 16 French sheath, it falls and you take it out. It was taken out successfully. This is a permanent filter, and this patient had actually severe back pain once this filter was placed. We remove actually a lot of permanent filters as well, but a permanent filter, if you leave it for more than 3 to 4 months, it becomes really difficult. Temporary filters, we removed the recovery 8 years later, which came out nicely. This filter was 6 months old, and we could not remove it because of that mushroom actually heals very tightly with the cava. But finally, we were able to identify the legs on a CAT scan, and there are 2 legs here, which is irritating the nerves, and went with an alligator forceps and pulled those legs out, and the patient immediately reported relief of pain. So not all cases go as planned. This is one of the filters which was embedded, and we did the same technique, which we took probably a couple of hundreds, and this one, actually, the leg snapped. Comparing the 2 before and after, turned out not to be one of the legs, it turned to be one of the arms. We went back and we tried with the snare, and it's all embedded within the wall, so we left it behind. This case is probably it is the most difficult filter I ever attempted. I was called from a hospital 3 hours away where a patient has a duodenal bleed, and the leg actually, when they did endoscopy, they found the bleeding around one of the legs of the filter, which perforated into the duodenum. The surgeon who was trying to remove it called me, and we tried to work over the phone to remove it, and finally they sent the patient to me. And it's one of the old recovery, if you see the knob here. And this turned out to be a 3-hour procedure where we tried every single technique we used over the past many years. Finally, went with an alligator forceps. 1 alligator forceps did not work, so we put 2 alligator forceps. And you see the second one coming to assist it. And eventually, with the 2 alligator forceps, it was successfully removed. So when you attempt this procedure, you should be ready with everything you have. So these are the 2 forceps holding them together, pulling it out. And strange enough, came out intact. This is the last case I'm presenting. This is a 63-year-old male who has a Gunter tulip for 4 years. And he started having PE, which is the statistics you presented. Basically, you have breakthrough PE. And when the cablegram was done it, the hook is actually embedded and the filter is actually tilted. The Gunter tulip has only 4 legs, so when it tilts, you don't have much filtration, and this patient was continuing to have PEs through the filter. This is a technique I'm experimenting now for the past year or so, trying just to put a series before I publish it, so keep it a secret. Take an alligator forceps, and you take a snare, and you actually load the snare on the alligator forceps as 1 unit, and use a 12 French sheath. So when you advance the alligator forceps, the snare is already up in the alligator forceps. And by pulling the hook away from the wall, you have the snare already on the alligator forceps. So you slip the snare into the hook, and you take our alligator forceps out, and you take the filter out. And we also always celebrate when we take every filter out. And that's a normal cablegram, which you should do, and we place a filter in place to protect this patient. So in conclusion, there are multiple techniques to remove these complex tilted IVC filters.
Yes, I can.
And in our practice, we attempt to remove every filter we place unless there is an ongoing reason to keep it, and we document it in the chart why we're keeping this filter in place. And we have good success with removal of these filters. Thank you very much.
That was excellent. You know, there's a reason I'm a non-interventional person after looking at that. I couldn't do that for a living. Well, just like you go to the movies and you get a trailer that shows you about the coming features, already this afternoon we've seen the name of Dr. Sharifi on one of our papers here. He's going to come on up next and give us some challenging case presentations with expert panel discussion. Welcome.
Good afternoon, everybody. My name is Mohsen Sharif. It's a pleasure to be here, and I'd like to thank the organizing committee for the invitation. I was charged with interesting cases on DVT and venous disease. Of course, nothing can surpass what Dr. Al-Masri just showed you. But we're going to switch gears from the lower extremity and the IVC and move to the upper extremity. I have no disclosures. I'm going to start with the case of a 75-year-old man who had presented with a non-Q wave myocardial infarction. He was taken to the cardiac cath lab and coronary angiography was performed. He was found to have multivessel coronary disease with a low EF of about 20%. He underwent bypass surgery, and his ejection fraction post-op rose from 20 to 35%. However, 2 days after bypass surgery, he developed unilateral left arm, neck, and facial edema, pain, erythema, tenderness, and induration. He did not have any central lines on that side, but had bilateral antecubital peripheral lines, and he did not have any drop in his platelet count. Venous duplex, which was performed, showed occlusive DVT of the brachial, axillary, subclavian, and the internal jugular vein. On heparin and warfarin, he did not improve, at least initially, and initially had progressive worsening of symptoms. Can we run this? Well, by the way, these cases are not Paget-Schroeder's disease, so don't think that way. Well, at any rate, you can see occlusive thrombus in the brachial and subclavian veins. Collateral formation. Next, please. Okay, this is going inside the internal jugular, and run that, please. Okay. You can see there is this chunk of material here, which actually had a rubbery consistency. It was not fresh clot, but it had occluded the internal jugular vein. And I felt I'm right in the middle of the clot. I should probably try to go back any further up, but there was really not much room up north. Next, please. And run that, please. Yeah, and then actually my catheter, my sheath was well below the thrombus here, this big ball here. Next. Okay, so we decided to go with the angiojet from the subclavian entering into the internal jugular vein. Next. Okay, that's our angiojet catheter, making a few passes. But again, we gave about, this was post-op, 10 milligrams of TPA, and tried to manually suction out as much as we can, but it didn't have the clot consistency, but it did provide establishment of some flow. So the clot was still left, this fibrous clotty structure was still there, but it did allow for passages of blood around it. This was initially, and this was after discharge. So some progress was made, the patient's symptoms improved, but as you can appreciate, there is still some edema left there. And one thing to remember, contrary to the lower extremities that you see almost immediate improvement in a few days, the upper extremities are not gravity dependent, so the application of compression stockings is not as effective as in the lower extremities, and it may take some time for the edema and the swelling to wear off. Moving on to the next case. Next case, labeled case 3. This is a 68-year-old woman who had a history of breast cancer and previous lower extremity recurrent DVT. She was on indefinite warfarin, and when she had presented, her INR was actually 3.8. She has had mastectomy and radiation to the right breast 2 years before. She had developed progressive right upper extremity edema pain, but without erythema. There was not a toxic inflammatory component to her symptoms. She had baseline lymphedema. Venous duplex was read at chronic DVT with small veins, no flow in the SVC, and DVT in the distal internal jugular vein. That was the reading. And when I did imaging before doing any intervention in her upper extremity, there was absolutely no normal truncal vein. There were just a network of collaterals in the brachial territory. So with that knowledge, I decided to go through the groin approach, femoral approach, and as you can appreciate, what was read as DVT in the internal jugular vein was actually a tight stenosis here, but there is still flow. And I tried to engage the occluded subclavian, and this is, I'm actually going to show you several views of this segment. This is from the caudal approach, and you can see the total occlusion there, some collaterals. I tried to pass my wire, but it was not successful. So next thing here is I brought my ultrasound machine to the closest and the biggest vein, which I thought was the remnants of a truncal vein, but it's actually the cephalic vein. And this is the approach, the view from the above. And you can appreciate the occluded segment here, tight stenosis here. And I actually tried to give it a try and see if I can go in the retrograde direction, but obviously that was not very helpful. So I brought my transducer as much as I could to the armpit and just cannulated one of those veins, and lo and behold, I could get access to the brachial and the subclavian vein. With some finessing, we could pass through the obstruction, and I managed to advance my wire. And you can see the collateral, which is here and serving as the major conduit for this patient. And this is balloon venoplasty. You can see the chronic stenotic segment here. Further venoplasty. And now we established flow, but still the collateral vessel is open. And we put a 6 millimeter stent there, and deployed it and post-dilated it. And now you can appreciate the collateral is gone and it's wide open. We switched her from warfarin to Xarelto in this case, and 1 year after, she's been doing well. Those were my 2 cases of the upper extremities. Thank you.
I have a question for you. How long have you followed that patient? I mean, have you seen that stent lately?
Yeah, we now have up to 3 years follow-up, and we every 6 months we do venous duplex imaging, and she's been doing well.
Yeah, the stents in the subclavian have a really bad track record, so that's good that she's open, because 50% of them seem to thrombose in about 6 months when you look at the data.
I think that's mostly with the ones who have not been maintained on proper anticoagulation. What we have her on is just an aspirin plus Xarelto. I think with the combination of the new oral anticoagulants and aspirin, the data may wind up being better than what it exists.
It doesn't seem to have anything to do with the anticoagulation in the cases that we were following for a long time, because it's the motion of the shoulder that causes intimal hyperplasia kind of rampantly. And we really don't understand it very well, but it doesn't happen elsewhere in the body like it does there.
Well, actually, the behavior of the stents in the venous circulation is distinctly different than the arterial circulation. What we have notice is that with looking with IVUS and also looking at the series that we have had, that new intimal hyperproliferation is not the means of obstruction in venous stents. This is contrary to the arterial circulation, where you have neo-intimal proliferation as the main cause. You have extension of thrombus from adjacent structures and outside compression as the result of venous obstruction. And true, it makes hypothetical, sense that if an organ like the upper extremity is at motion too much, you may have that. But in the few cases we have had, we haven't witnessed that.
Our next speaker needs no introduction.
This is a title that came to me, like Dr. Rook said earlier. I'm going to try to. This is not my title, but I accepted the assignment of doing this. So I'm going to show you that it could actually be the shortest talk of the day. So why does the progress in venous stenting remain so disparate from that of the arterial environment? I think we understand that why is a venous scene so different from the arterial scene when it's half the circulation and we all know that it's important? Or do we? Well, I think that one answer is money. I mean, I could stop right there. Money for education, money for training, money for patent development. I mean, I've got a lot of ideas that I can't afford to patent because it's so expensive once you go into the international area to patent your new ideas. Money for animal training or animal testing of a new idea or a new device. This is extremely expensive. So I think that's one of the big reasons why it's different, because nobody who has the money wants to spend it on the venous side. All the money seems to go to the arterial side, be that coronary or peripheral. Well, if we elaborate it just a little bit on this, let's talk about, does that even make sense? I mean, the numbers show that for every single person with peripheral vascular disease, there are 9 people with venous insufficiency, a venous disease that's treatable in an outpatient setting a lot of the time. We're so familiar with arterial disease and plaque and everything that we don't even think about what's different about the veins. People are really, we always joke about the fact that arteries are red and veins are blue. The arteries go down, the veins come up. I mean, little kids learn that. But let's look at what's different about arteries and veins. And contrary to what Dr. Sharifi just said, and I respect you a lot, you know what? I started looking at what's inside these occluded stents. And we started sanding out the pathology because I thought, what is that stuff inside these occluded stents? And it turns out that it is, in fact, some of this smooth muscle proliferation. It's coming back looking like arterial stent material. It's very interesting because there's a little bit of smooth muscle here, and there's a lot of smooth muscle on the artery. Look how much thicker the smooth muscle is. And beside that, on the artery, you have an external elastic lamina and an internal elastic lamina, which don't exist in the vein. But lo and behold, if you angioplasty a vein, you get recoil and you get spasm, even though you don't have a lot of this internal and external elastic lamina. In addition to that, you have the issue of valves. So you have a bigger lumen on a vein, generally, than an artery. You have this internal obstruction of the valve for your hardware. The adventitia is somewhat similar, but they're quite different, aren't they? And they respond very differently. The arteries are much firmer because of that very significant triple layer, whereas the vein walls are quite thin. and veins tear. If you dilate a normal vein, it doesn't just have a little hole in it, it can slit all the way down the side. It'll tear longitudinally. So they behave a little bit differently than arteries in many ways. Now, some of the other differences that I talk to people about are the fact that generally in arteries you have shorter lesions, you have high pressure, you have less real estate to treat and fix, and you're dealing with plaque, which is another entity, complicates things for embolization or, thrombosis. But the PTA is usually effective in arteries because of the components of the wall. You can remodel it. You can cause that purposeful injury that Andy Craig described, and you can actually get remodeling. You don't really get remodeling in veins. Veins are sort of like a cat. You can angioplasty it, and it just turns around and looks at you and says, so? Didn't do anything. Because we know that we angioplasty veins, and they don't really change very much. So if you're dealing with veins with thrombosis in them, and you're more familiar with arterial disease and treating arteries with lytic therapy or all these devices, you're going to have difficulty because veins are a lot more real estate to work with. You've got low pressure, you've got slow flow or no flow, and so how are you going to get your TPA through your veins when you don't have the arterial flow coming from behind to push it? You have to push it with a high volume, low dose lytic infusion compared to on the arterial side where you can do a high concentration, low volume infusion, almost the opposite. So, and the way they respond to anticoagulation is a little bit different because in a low flow state with no pressure, you need more anticoagulation to protect from thrombosis than you do in a high pressure system that is pushing the flow through for you. So you can angioplasty an SFA and the high pressure will protect you from thrombosis, whereas on the side of the venous system, you need to be anticoagulated. So in my mind, there's a lot of darkness associated with venous disease. It can be down the street or it can be next door in your primary care physician's office who didn't train with DVT, doesn't know what you do. So it's incumbent upon all of us to kind of keep teaching our colleagues about what we can do. Now, right now, venous insufficiency and saphenous vein ablation is the big thing because it's a procedure that can be done outpatient. The reimbursement has been decent. We actually got burned quite a bit when we started doing it quite well and told the government on those RVU questionnaires that, yeah, now I can do it in 20 minutes. I mean, the minute you tell them that you're good at it, because it took you a year or two to do it, well, then they cut back your reimbursement because it doesn't take as long. But this is a patient that is a complicated patient, but a lot of people now are embarking in the field of saphenous vein. Now, a lot of people, including our colleagues in every field of vascular intervention, are deciding that the simple iliac compression is an outpatient procedure, and that in itself is something that they are looking into. And I think it's difficult if you don't know the whole disease process to just start doing a procedure. IVUS helps keep people out of trouble. It helps them measure properly. Some of that dilatation you see in the common iliac proximal to this is pre-stenotic dilatation, just as you have in an artery post-stenotic dilatation. So the real question, I think, is why is the actual treatment of venous disease so disparate from the arterial disease? Not stenting in itself. It's actually the entire field of treating venous disease is quite disparate from arterial disease. There's just not as much attention paid to it, and I think I have a list of people. Now, I want to show you two quick cases. These cases are from last week, believe it or not, and if I hadn't been there on my birthday, seeing these people, they would have both been discharged. They would have gone home on Lovenox, both of them. This is a lady, first lady, She had 3 days of procedure. She had only 90 minutes the first day, 1 hour the second day, 1 hour the third day. She had a big right leg. This is a lady who had a injury on her saddle. Her horse bucked, she rose up, she came back down on the saddle horn, and she bruised herself very badly right in the groin area, right here. And for about 3 weeks, it didn't bother her too much until her whole leg swelled up and she had phlegmasia. So she had a chronic condition that was smoldering, and then an acute, and it's not a May-Thurner, it's not a May-Thurner, but it turns out that she has a prothrombin gene mutation that she didn't know about. So she had a perfect storm of immobilization following an injury, and you can see all the acute clot here and here. This lady was going to be sent home because no one took a look at her iliac system. This is her femoral system after 1 day of catheter-directed TPA. It cleaned up beautifully. There was some thrombus in the iliac that cleaned up and some chronic thrombus that took a little bit longer, but basically she was treated for 48 hours and then anticoagulated to a therapeutic level. And her leg went down to normal. This is the other lady in the other room who had an acute exacerbation on top of a chronic condition. And it turns out that she had had her original DVT almost 20 years ago. But now she comes in with an IVC occlusion and iliac occlusions and an acute DVT below that, which you can see here. She also was only treated for 3 days, and this is the result on day 3, stenting her entire bilateral iliac and cava. I'm actually amazed that we did both of them within 3 days. You can never tell if the wire is going to pass easily or it's going to take a lot harder because you have to be so careful in the chronically occluded cava. But the fact is, which I can't get over, is that the ER doctor, the internal medicine hospitalists, and even the intensivists had all signed off on both of these patients until I went to look at them and measure their legs and say, hey, these ladies are pretty symptomatic. Why are we sending them home? The one lady had had PEs. As a matter of fact, both of those people had positive CT for pulmonary embolus. They were just going to anticoagulate them, send them back out. And now both of them have their lives back. So, I mean, it's so important that we learn how to treat this condition and spread the word. Thank you.
All right, well, what would my speaking role be if it wasn't to change the batting order periodically? I'm going to give a talk, but then we're going to hold for the break. We're going to do the live case because we need to keep it on time for them, and we'll have our break right after the live case. So if I could have my side. All right, well, here's a topic you are not expecting to hear about at this meeting. ABO blood type and the risk of venous thrombosis. What's up with this? Well, no conflicts here. Let me start with just a few basic assumptions and some broad generalizations here. In a population, the number of venous thrombotic events that you're going to see due to a particular clotting risk factor is going to depend on a balance of things. It's going to depend on how common the risk factor is and how potent the risk factor is. Luckily for us, the strong factors tend to be less common, and the most common factors tend to be weak ones. Now let's think about where this takes us. Take something like protein C or protein S. These occur in somewhere between every 200, maybe 500 people out there. They'll have a defect. In terms of population-based thrombophilia, we could consider those things, this is to be fairly rare. And there should be a little slide that pops up there, but I'm not getting it. Anyway, they may be relatively rare, but if you think about it, they give you anywhere from a 2 to an 11-fold increase in having a clot. So they may be rare, but they're fairly potent. And you can picture a rare steak and an atom bomb popping up next to those two things. Won't do it for some reason. Let's contrast that to what we see with factor V Leiden here. Factor V Leiden is present in about 5% of the population. So it's as common as a common cold, but the relative risk of having it is small. In fact, it's like a little kitten out there, to quote Patty here, talks about the cats there. Its overall risk is maybe just barely more than a one-fold increase. So, what have we got here? We know that protein C and S are 10 to 20 times stronger factors than factor V Leiden, but that factor V Leiden is maybe 250 times more common than protein C or protein S. So let's do the math. Somebody has eliminated all my illustrations here. If we do the math, we see that it's actually the factor V Leiden that's producing 12 and a half, 20, 25 times more clots in the population than the protein C and S are. So the weak but extremely common one factor, if it's common enough, it can produce more clots than these powerful factors that we typically think about. Well, what other weak factors are out there? We've got the prothrombin gene mutation. That's a weak factor that's out there. But what if I told you that there was one other factor that's weaker than all of these, or maybe equal to possibly factor V or prothrombin, and yet it's so common it produces more clots than any other? Well, that would be, boy, this talk is going to be difficult because we're going to have half the slide for it here. Let's see what I can do. We've got, we want to talk about the ABO blood types. That's where this talk begins. And remember that we've got 4 major surface antigens, which you can't see here, but there's an A antigen and a B antigen, so that if you think about it, you can have as many as 4 different blood types. You can have a cell that's got the A antigen on it, a cell that's got the B antigen, one that's got the A and the B, and one that's got none. I don't know, is it possible for you to run it from back there? Would I have any more chance of having things animate or pop up? Oh, there we go. That one worked. All right. So there we go. We have the 4 major types here. And these things come in a worldwide distribution. This shows, for example, the type A blood. You can see that it's practically non-existent in South America. It's very common in parts of Australia or the tundra or the Great North. Why? Well, it's thought that maybe some of these alleles are useful at preventing malaria. That might be an explanation for why we have these various blood types. Here we go. Now we got our pictures in. It's important to understand then that different populations will have different ratios of A, B, and O blood type. And in the United States, we fall into basically 2 broad categories. About half of us, just a little bit less than half of us, have type O blood, or non-A, non-B as we sometimes call it. And the other half, or slightly more than half, have either A or B or AB. That's how it breaks down. Now, a fellow named Jick, publishing in The Lancet, he was responsible for dispersing heparin at his hospital in England more than 35 years ago, and he made an observation. He noted that he was giving a lot more heparin to patients, or giving heparin more often to patients who had type A or B or AB blood than you would have expected based on their prevalence in the population. So he came to the conclusion that there was something about these non-O blood types that predisposed to clotting. And indeed, there's been lots of other studies since then. There's the LIGHT study, published in 2007, that basically confirms that type O blood is less of a risk than non-O. There was another big study, meta-analysis actually, published in 2012, came to the same conclusion, thought the odds ratio was about 2 for having non-A or non-O type bloods. There's still some things that we don't understand, or things that become controversial about this. Is it the A or the B? Is one of them more important than the other? One study out there concluded that it was the B that was the risk factor, not the A's, but we'll come back to that in a minute. Also, there's been some subgroup analyses. Pregnant women, for example, we all know are at a high risk of having clots. It turns out that they seem to show this O, non-O breakdown more than other types. They seem to be particularly sensitive to blood type. You can contrast that to work done by one of Dr. Zierler's partners here, Dr. Mark Meisner, which looked at a large number of people who came in with trauma-induced DVTs, and they didn't find any breakdown in blood clots. So, breakdown in blood type. O's and non-O's seem to get clots after trauma at an equal rate. So, there's still some things here we don't understand. However, you always got to, dance with the girl you brought to the prom here, and in this case, that girl would be Dr. John Haidt. He just retired this week, but he's been our thrombophilia expert at Mayo, and he published this rather sentinel paper a couple of years ago in which he pretty well demonstrated that the population attributable risk to blood typing was greatest for ABO non-O type blood. So you get more clots in the population, according to John and his work in our Olmsted County database, from having non-O blood than you do from having factor V Leiden, prothrombin gene, or anything else. Now, why would that be? Well, one possibility relates to von Willebrand factor. Von Willebrand factor, shown here, it adheres to the wall of the cell, and it's a nidus upon which clots can form. If you don't have it, or you don't have enough of it, you get a form of hemophilia. If you have too much of it, at least theoretically, you'll be predisposed to clotting. Well, what we've found is that people with type O blood have about 30% less von Willebrand factor in their blood than other people do. So this may be the link here. Now that link also gives us one other little iota of food for thought here. If von Willebrand factor is something that lets clots not only form better but adhere to the wall, then maybe people with A or AB or B blood not only form clots better, but they adhere more to the wall. Contrast that to people who have O blood, don't have as much von Willebrand factor. Those people may be less likely to form clots, and when they do form them, they might be less likely to adhere to the wall. Well, curiously, my friend here, Dr. Patricia Thorpe, has written a thought piece about this, in which she has pointed out that in her experience, not only do non-O's have a greater risk of clotting, but they seem to have a disproportionately higher incidence of post-phlebitic syndrome. Now, if you believe in this von Willebrand idea, perhaps that's because when people with non-O blood form clots, they tend to adhere to the wall better and they're less likely to recanalize. And remember, we've heard about that today, that some people recanalize well and other people don't. So perhaps these people with clots and non-O blood get more post-phlebitic syndrome. Of course, what would the flip side of that coin be? If your clots don't adhere as well, then maybe you'd wind up with more pulmonary emboli. And in fact, there are some studies looking at people with von Willebrand disease that suggest that even though these people are much less likely to form clots because they have a form of hemophilia, when they do form them, they're much more likely to flip those clots as pulmonary emboli. So we have a very interesting idea here. Anyway, the conclusions are that non-O is a risk factor for thromboembolic disease, and that it's probably the greatest single risk factor in the population. It might be associated with an increased post-phlebitic syndrome, and O might be associated with increased PE. Now, I'm just going to end this with sort of one further implication. If what I've said, or what I'm suggesting is true, should non-O blood be counted as a thrombotic risk factor? Well, think about, please. All right, is there any chance you could back it up and possibly if you advance those last couple slides, are you able to make them animate the way they should? Well, what I had shown here is that if you use the Caprini score, you get up to 3 points for having factor V Leiden, for having a prothrombin gene mutation, or for having any other type of clotting abnormality. If that's the case, maybe we should be awarding people points on these DVT risk scales, like the Caprini scale, for people who have non-O blood. And that was where I was going to take the brilliant conclusion of this today. So anyway, it also raises a couple other points. Should patients with non-O blood receive more aggressive prophylaxis against DVT? And how about should patients' blood type influence any aspect of their anticoagulation therapy? Should they be treated more intensely or treated for longer periods of time if they have non-A, non-B? Well, I guess maybe I've run out of slides, so thank you very much. Now Patty's going to bring us to the live case. Are you? Oh, it's changed.
That was brilliant, Tom. I liked it. And I do think his conclusions are correct. I think that's where we're going. I anticoagulate my A positive and A negative patients more than the O's. But I'm going to give my next talk, and then we're going to have a break because the pendulum has shifted in Phoenix, so they want to have just a little bit more time to get ready. So innovation in venous stents, new versus tried and true. Well, I don't want to show any bias towards any particular company because I work with all of them all these years. I'm only a consultant for the volcano people, but they're all my friends, and there are many stents out there. So I'm going to introduce you to some of the designs. We'll talk a little bit about what makes the designs work. And there are so many variables as to whether a stent will be patent that part of it is probably the design, and other things are involved for sure. What makes a good stent design? Radial force, so it keeps the vessel open as big as you can. Flexibility, delivery system ease, durability, low thrombogenicity. I have a patient who had a radiofrequency probe put through her vein, the occluded vein, trying to find the way. We were talking about blunt dissection, sharp needle dissection. He used a radiofrequency probe and he burned. He burned all of the tissue around. It's almost worse than radiation burn. So she has such horrible scar tissue, no stent that we can try will keep it open, even though we've tried. The balloon will open it, but the stent won't. So radial force will meet its match with really bad scar tissue. It will meet its match with arterial compression at the iliac right up against the bone, depending on the lordosis or the curvature of your spine. So even though these are all the ideal forces, these other variables enter in. Then there's this big discussion about open cell versus closed cell. Perhaps you know that the wall stent is woven out of 9 strands. It's put on a machine with 9 spools, and they all move simultaneously, and they weave the wall stent. And then it's cut at the lengths they want and the width. They can generate certain widths and lengths. Whereas all the nitinol stents are cut, diamond cut, out of a piece of nitinol, a single piece of nitinol. It's a tube of nitinol, and they have these fancy diamond cuts that will create the interstices either in a layer of V's or a layer of W's. We'll see that some of them are spiral now. So here is the wall stent. It was, of course, designed for biliary use. The only FDA indication for the wall stent right now is for the subclavian in association with fistula problems for dialysis patients. But the wall stent has been around since the early 1990s, and it was the first stent that we had available to use in the deep venous system. And as I shared with you, my experience with it in the subclavian is miserable, but in the iliac system and the cava, it's been excellent. 20-year patency on patients that we've stented in the late 90s. Transhepatic biliary stent, that's a nitinol stent that came out quite a few years ago, as well as the SMART stent. My recollection is one of the first nitinol stents was available. It's much harder to see than the wall stent. The wall stent is algiloy, which is a combination of some metals, not including nitinol. And nitinol has one issue that I'd say 2 to 5% of the population is allergic to nickel. It gets an inflammatory response. You can always tell if somebody gets a black on their hand when they hold a nickel. They have that allergy. But physicians like nitinol stents, even though they're harder to see because they're a little bit easier to deploy, they don't seem to jump and they don't foreshorten. So the deployment is nice, but they have open cells, and so they have a tendency to contour to the inside of the vessel. So if you have a vein that's full of lots of old chronic thrombus, the nitinol stents will all kind of take on a little bit of a zigzag or irregular look, whereas the wall stent will kind of give you that nice straight appearance because it doesn't let anything protrude through the interstices. Now, the Zilver stent series, there's a series of Zilver stents by Cook, who then invented their Venous stent. But the original Zilver stents are all for arterial. There's a drug-eluting stent. There's a self-expanding peripheral stent. But you can see by their diameters that they're mostly designed for femoral arteries, 4 to 7 millimeters, 5 to 9 millimeters. All the veins we're treating are usually bigger than that. This is a self-expanding balloon stent, and we don't use that very much. We learned early on that Palmaz stents can be compressed in the common iliac area. We've tried some self-expanding EV3 VisiPro stents inside wall stents when they have lots of intimal hyperplasia, and it does do a very effective job of pushing it back. But even within a wall stent, if they're under the inguinal ligament, they can still be crunched a little bit. So self-expanding stents have never been really the favorite in a venous system at all because they don't have the artery to protect them from being compressed. Now, this is an express stent. It's a nitinol stent too. It's pre-mounted. And it was designed for iliac, but I show the interstices. It's an open stent, and you can see that it's very flexible. The more open, the more flexible. The more closed, usually the less flexible. So this combination of how flexible it should be to go around curvaceous veins like the iliac vein versus have radial force is always the design dilemma. This is a Supera stent. It comes out as a bunch of coils, a series of coils, and it promises to have very good radial force if it's properly deployed. The big if, though, you have to get the coils just close enough because if they're spread out too far, they lose all their radial force. So it's kind of like a slinky. You know, if your slinky's far apart, there's lots of big holes in between the wires. If it's close together, it's pretty impermeable. So the Supera has a good concept, but in reality, for me, it's been more difficult to deploy properly. The Cook Zilver Vena, self-expanding, also with open struts cut out of nitinol. They have an ongoing trial. This is a stent designed just for veins, so it is already in clinical trials, and it's 14 to 16 millimeter size. Now, most recently, Dr. Naglin and Raju have been involved in designing a stent that's been years in the making, but their clinical trials started this year, actually the end of 2014. They're near the end of the first phase of enrollment, and it's called the Venous stent or Vici venous stent. It's a nitinol stent, And it's a closed cell design. So they're trying with a nitinol cutting tool to mimic more the design of the wall stent. So they've tried very hard to make a closed cell design in nitinol, maintain the flexibility of the nitinol, have larger diameters of 12, 14, 16, and they have longer lengths. So it's a contribution to, it's a dedicated venous stent, and with the trial they're hoping to get safety and efficacy and then FDA approval. So I wanted to share with you some of the information gathered from the Charing Cross meeting most recently, because it was in a little booklet that I looked at, and I thought, this is pretty interesting. So I don't know how many people were included in this survey, maybe close to 1,000, because they had a big venous workshop there. And this is the answer. Is stenting below the inguinal ligament reasonable? Well, 57% said yes, 43% said no. And people are reluctant to go below the inguinal ligament because they think the stent's going to kink. But in reality, it doesn't, because it's counterintuitive. Let me show you these images. This is a patient sitting up on the table, and the intensifier is way over to the side, so it's a lateral view. Hardly anyone ever does this, so I'm showing you these images because they're not very prevalent. Anyway, as you can see, this is the IVC coming down. The spine is right there, and it curves forward towards the femoral heads right here, and it dives down posterior before it comes up by the femoral head. And the next shot shows you the extension of that coming up by the femoral head, so it's coming from this curve down below up towards, and as it goes across the femoral head, which is right where the crease is in your groin, the stent is perfectly straight. It doesn't kink the stent at all. An arterial stent won't kink there, a venous stent won't kink there. That is why we can extend the stents down to the inguinal ligament, past the inguinal ligament, under the inguinal ligament, and into the inner trochanter area with very good results, which is where you usually find good inflow. So you have to extend your stent to good inflow, because you wouldn't put an aorta bifem graft into a patient who had no runoff. By the same token, you shouldn't be stenting anybody who doesn't have good inflow, or you won't keep your stents open. Now, this is a patient who had 2 or 3. It was always hard to count them because they were overlapping. There are 2, I think, nitinol stents here. There are probably Cordis stents here. And then there was one 10-millimeter stent stuck right here at the common femoral. Well, there were 3 stents that had been there for 5 years, and they all clotted off. And this poor guy had had a bad leg for a number of years until he acutely occluded everything and came in for another ER visit, and he came to our hospital. Flexibility is more important than radial force. Most people think it is. I mean, it's pretty close, about 58% to 42%. Flexibility with your open cells is what causes more fractures, but people think that that's a desirable quality. Most of the stents we put in don't go around too many curves, so for me, the radial force is actually the biggest issue. But here is an example of a nitinol stent completely compressed under the artery at the spine, right at the bifurcation. I have many of these pictures. 85% of the stents that we open up from St. Elsewhere places are nitinol stents. A few are wall stents, but almost all of them are nitinol stents. Is IVUS necessary for venous stenting? Actually, the vote was almost 50-50, I guess. 45% yes, 65% no. I should think that there are a few standouts for people who think they can see. I myself admit that I missed a number of cases of stenting that I should have stented, that I didn't stent before I started using IVUS. So long-term patency means you don't have any intimal hyperplasia, no DVT, no strut fractures. And stent failure is related to good inflow and good outflow, just the principle of putting a graft in anybody. You have to have good inflow and good outflow. It means it goes up into the IVC far enough, and it goes down low enough to get good inflow from the femoral vein. Occasionally, a person will have a huge profunda vein that's taken over from an occluded femoral, and that'll do the job. But we usually don't like to stent into the profunda. We stent into the level just below where the profunda comes in. Late thrombosis is usually related to compression at the common iliac artery, like that one I showed you. A lot of nitinol stents go down there, or like the other man who had inguinal stents. Too small of a stent in the venous system, it will also not stay open too long. Late restenosis usually occurs where the stents overlap, so you want to overlap them enough and not park them right under the inguinal ligament. Gaps between stents have a tendency to get intimal hyperplasia or thrombosis at the edges, and subtherapeutic anticoagulation can cause that. Now, I told Dr. Sharifi that I have a long list of people who have been put on Xarelto who have failed on their stents, so there must be something about some people, like Dr. Rook was saying, that don't do as well on Xarelto as other people do. There's a human variability there that we don't quite understand. So future ideas might include biodegradable stents, better stents for subclavian veins, longer stents. Drug-eluting stents may inhibit intimal hyperplasia. So those are some of the ideas about the, I don't know if it's tried and true, but those are my ideas. Thank you.
All right, Patty. Well, we either got to give these people a break here, or we have to come up with a case. Are we?
The break is, I think they're right after the break. Is that true?
This crowd they've stuck with us here on the tried and true. I know I'm in Chicago when I see votes that come out 65% to 45%. I noticed that.
That was in London. Oh, Charing Cross.
Yes.
Okay, break.
Break. We're going to take a break. And how long, Patty, do we?
15 minutes.
How about we just cut her down to 15 that while they're getting the case still set up? Thank you.